I would love to show you the 4 assessment or the 5 assessment. The first assessment is the assessment findings of the eyes, assessment findings of the ears, assessment findings of the nose, assessment findings of the throat, and lastly, assessment of thorax and the lungs. So, first is the assessment of findings of the eyes. What is the eyes assessment of the eyes anyway? Well, the eyes is the sensory organ, as well as William Shakespeare. The eyes are the window of our soul. It is very important and dedicate parts of our human body. Its function is to collect light from the visible world around us, then converts it into nerve impulse. The signals are transmitted by optic nerve to the brain, which then forms an image, thereby providing a sight. For the planning of assessing the eye structure and the visual acuity, we have placed the client in an appropriate room for assessing the eyes and vision. The marks must be able to control natural and overhead lighting using some portions of the examination. Client should be seated comfortably in a well-lighted room that can be darkened for palm examination. First, external eye structures are examined, then eye function is tested, followed by the ophthalmic examination. For the delegation, due to substantial knowledge and skill required, assessment of the eyes condition are not delegated to the unlicensed assisted personnel. However, many aspects of observed during the usual care and may be recorded by persons other than the nurse. Abnormal findings must be validated and interpreted by the nurse. For the equipment, we have cotton tape applicator, razor, examination gloves, millimeter ruler, pen lights, sailing scans, or e-chart, opaque card, nerve vision card, or newsprint. Now let's go implementation. The procedure. First is the preparation. Assemble the equipment and supplies. Procedure. Example to the client what you are going to do, why is it necessary, and how can client operate the procedure. Hi sir, I am Richie Pintor from PS1 Biner. May I know your name please? Okay. Tiger. Hi sir Tiger. Today I'm going to do an assessment to test your eyes if it has damage or not. Next is we have to wash our hands, observe appropriate infection control procedures, provide for client privacy. You may close the door or maybe close the windows. Next is to provide for client's privacy. Determine the client's history of the following, which is the family history of diabetes, hypertension, blood dyscursia, or eye disease, injury or surgery. Let's visit to an ophthalmologist. Hygienic practices for correctiveness lenses, signs of symptoms of eye changes in showing for photophobia, itching, or pain. Current use of contact lenses or eyeglasses. Then next is for the assessment, we have the external eye structure examination. First, we must inspect the eyelids and lashes for the following: position and appearance, and the blinking. Next is to inspect the conjunctiva, vulva, and palpebral mascara, clarity, and the clearance by separating lids with thumb and index finger and asking the client to look up, down, and to either side. Sir, can you look upside down? Okay, supposed to be our patient downward, side by side. So, I don't have a real patient, so supposed to be your eyes are good, equally distributed and curved slightly outward. So, next is we have to inspect the cornea using oblique lighting or appearance. Supposed to be, it is transparent, smooth, and moist. Then, inspect iris and pupil for the following shape, equality, color, and iris. So, as I inspect, I can see that it is rough, equal, and uniform in color. So, next is inspect the lens for clarity. So, this is the inspect for the palpate lacrimal apparatus for the following. The appearance is going to pressure applied at next outside of lower orbital rim. So, the puncture or small elevation of the nasal sides of the upper lower lids, mucosa is color pink. So, no tenderness or discharge noted when pressure is applied. Okay, good. So, for eye function testing, check visual acquisitions, that's distal vision with snellen chart or 20 feet from the client. This is a snellen chart or 14 inches of newspaper from client's head. So, here it is. 20/20 with no hesitation is printing. So clients will sprint and 14 inches without difficulty. Supposedly, so we are good. So next for vacant face clients at distance of 2 to 3 feet, and the client is look directly and head cover eye directly opposite to each other. So may client and okay. So here it is. Check accommodation as clients at the poster on the non-object 3 to 4 feet away. And move object into client's nose. Pupils cover and constrict as objects move in towards the nose. Pupils response are uniform. So next is check extra ocular movements as the clients follow objects as it move in the 6 cardinal feet. So first is upright, up left, and down right, and down left. So both eyes move in a smooth coordinated manner in all directions. Good. Check response to the light. Sure, cornea line reflects by asking client to look straight ahead and then shining light towards facial midline. So, mom, please look straight ahead. Then check the direct pupil response by asking the client to look straight ahead and approach each eye from the client side with a pen light. But this is a pen light. Mom, can you look straight forward as I do it? So, reflects the noted in the same location on both eyes. Elongated pupil are constrict. Next is check on consensual pupil response by asking client to look straight ahead and approaching each eye from the client side with a pen light. So, pupil opposite the eliminated constricts simultaneously. Okay, good. Check for abnormal movement using a uncovered test as line look straight ahead, covering one eye with a cover card and observed uncovered eye for movement. Uncovered eye does not move as opposite eye as it covered eye. Covered eye does not move as cover is removed. So, lastly, we have to do a hygiene, document all the findings in the client record. So, now let's proceed to our hearing and or ear assessment. So for hearing, we have the otoscope with go batteries. Supposed to be these are otoscope for young children so tuning fork or 500 probe on 1024 Hz. So this is our tuning fork. So for the planning should be comfortably seated in such a way that you can easily visualize both ears. First, examine the external ear, then the ear canal and the tympanic membrane with otoscope. Supposedly these are otoscope. Finally, this is the hearing function. So for the implementation, first is the preparation. Suitable equipment and supply, which is the otoscope with several sides of ears and specula to save time and energy and effort. So for the procedure, explain to the client that you are going to do, why is it not necessary, and how to solicit cooperation. Well, ma'am, sir, I am Richie Pintor from Base 1 May I know your name, please? Oh, his name is Tiger. So, today I'm going to perform a ear assessment for you, sir. This is to check your ears if it has damage or you have hearing problems. By doing so, I need your cooperation. So, I hope you will bear with me and do whatever as I ask. So then, wash our hands and observe other appropriate infection control procedures. Provides for client privacy. You may close the door, windows, or what our patients want. Supposedly this is a room or hospital room. So determine a history of the following: family history of hearing, problems or loss of blood or presence of any ear problem, medication history, especially if there are complaints of ringing in ears, any hearing difficulty, as factors contributing to it, and how it interferes with the activities of the relieving use of a corrective hearing device from whom or was obtained. Then, position the client comfortably seated if possible. Then for the assessment, for the following: size and shapes. So for the ears, are equal size and similar appearance. For the position, alignment of penile with corner of the eye within the from a vertical position. So the lesions and discoloration, skin smooth and without noodles or color pink. Then palpate external and tender or freckle struggles. Palpate master passes for the following tenderness. No tenderness or pen when palpated. So for the temperature, is warm. So from here. For edema is easily palpated. So, then inspect auditory canal using otoscope for the following cerumen or the earwax. The color is black, dark red, gray or brown. So the color as I see is gray. So it is normal. So the consistency is waxy. Again, normal. The odor is none. So if it is flaxy, salt and hard, it is okay. Then for the appearance, the canal will uniproper tympanic membrane or TM visible. For the tenderness, little or no discomfort and in manipulation of tine inner 2/3 of canal if tender is touched if it is touched rusticulum. Next is we have to inspect tympanic membrane using otoscope for the following colors. So it should be very gray, shiny, and translucent if it is normal. Then it is fairly gray. So for the consistency of it is intact major movement when swallowing. So landmark is phonotype or handle of malleus and close process of malleus is easily visualized. So when see, so except for the third function of yours is the hearing ability, whisper, words, and 1 to 2 feet behind client, then hold. 1 to 2 inches from 2 clients for the client's ear. 1, 2, 1, hold. So the client's hip was able to hear whispered from 1 to 3 inches. So lateralization of sound revertis, like activity toning fork on center top of front. Possibility is radiation is both in ear. Is heard in both ears. Comparison of ear conduction agent to bone conduction training test. Place toning fork on master brass until no longer heard and then move it to front of ear. AC, BC, or AC was as long as BC. Then perform bumper test for the equilibrium by client's hand with feet together, first with eyes open, then with eyes closed. Hold your arms around the client to prevent hold. Stand straight with minimal swaying. Then gather all the equipment used. Do a hand hygiene, document findings and the client record, location of skin, lesions of body surface, diagram. Now proceed to the nose and sinuses assessment. As a nurse, we can inspect the nasal passages very simply with a flashlight. However, it is a spectrum and pen light or an otoscope with a nasal attachment facilitates examination of the nasal attachment. Assessment of the nose includes inspection, palpation of the external nose, upper third of the nose bone, and the remainder is frequency of the nasal cavity and inspection of the nasal cavity. If the client report of difficulty of abnormality in smell, the nurse may test the client olfactorism by asking the client to identify common odors such as coffee or this is by asking for unclose the eyes, gas containing dust and enter the client's nose. The nurse also inspects and palpates the facial sinuses. For the planning, we have the delegation assessment of the nose and the sinuses is not delegated to unlicensed personnel. However, many aspects are received during the usual care and may be recorded by persons other than the nurse. Abnormal findings must be validated and interpreted by the nurse. For our equipment, we have nasal speculum, flashlight, or pen light. For the implementation, we have the preparation. First is to assemble the equipment and supplies. Then the procedure, explain to the client that you are going to do. Why it is necessary to solicit client cooperation. Hi sir, once again I am Richie and you are Tiger. And you are now we're going to nose and sinuses assessment. So I hope you will cooperate again and obey what I ask you to. Then wash our hands and observe other appropriate infection control procedures. Observe appropriate infection control procedures. Provide for client privacy. Determine client history of the following: allergies, difficulties of breathing of nose, sinus infections, or nosebleeds, or any medication taken of any changes of smell. Position the client comfortably seated if possible. Then for the assessment, expect and the external notes of any deviation is safe size and color and flaring or discharge from the nurse. So the symmetric is no discharge of no uniform color. So lightly palpate the external notes to determine any remaining areas of tenderness, masses, and displacement of bones and cartilage. So it is not tender and no lesions. So determine the patency of nasal both nasal cavities as the client close the mouth and knows to repeat the procedure to assess potency of the opposite node. Ma'am, can you close your mouth? Okay. Possibly, oh sir, close up. So, next is inspect the nasal cavities using a flashlight and not speculum observe for the redness, swelling, and growth and discharge. So it is mucus, okay? Watery discharge and no lesion. For our last assessment for the nose is expectation in between the nasal chambers. So the nurse's septum intact and in midline. So for facial sinuses, we have to palpate the maxillary and polar sinuses for tenderness. So it is not tender. Gather all equipment used to hand hygiene, document findings in the client's record. Now, let's go to our last assessment, which is the second to the last assessment, which is the assessment of the throat. So the throat and pharynx is located behind the nose and the mouth. The upper part of the throat is the nasopharynx. So below the nasopharynx lies the oropharynx, and below the oropharynx lies the laryngopharynx. So for the equipment needed, we have the pen light, tongue blade, depressor, small gauge, and clean glass. Supposed to be I have gloves. So for the implementation, we have the preparation, assemble equipment and supplies. So for the procedure, explain to clients what you are going to do, why it is necessary, and to solicit clients' cooperation. Hi sir, I am once again Richie and you are Sir Tiger. Today, for our second to the last assessment, we have, which is the throat. I'm going to examine your throat for your own good. So I hope you will cooperate. Then wash our hands and observe other appropriate infection control procedure provides some kind privacy. Determine the cause for the of the following infection, for pain, frequent throat, tonsillitis, throat surgery, or taking any medication. Next is position the client comfortably, stay seated if possible. For the assessment, inspect the oropharynx for the color, which is pink. The landmarks, inspect to avoid eliciting the gag reflex to expose one side of the oral pharynx. Press a tongue blade against the tongue on the same side about halfway back by the client. Tilts its head back and opens the mouth wide. Use a pen light for elimination if needed. So, ma'am, sir, can you open your mouth? Okay, supposed to be a patient open the mouth. This is a pen light. So, okay, the tonsillar pellars is mitral tonsils, presence and less surgical movement without executive of uvula and midline and presses on the phonation. So, next is inspect the tonsils for color, discharge, and size. So, it is pink and smooth. No discharge of normal size. So, refer out. So, next is elicit the gag reflex by pressing the posterior tongue with the tongue depressor. Suppose we have a tongue depressor. So, it is present. Gather all equipment used and do a hand hygiene, record and document, and use narrative notes when appropriate. So that is for our throat assessment. So for our last assessment is the thorax and lung assessment. Thorax and lung assessment is the evaluation of the thorax and lungs is one of the most essential components of a complete physical examination. So it needs a thorough assessment and proper recording of the findings. The conventional systematic approach or sequence in evaluation of the thorax and lungs involves inspection, followed by palpation, precaution, and then auscultation for the anterior and lateral, and also the posterior side of the thorax. So for the planning, for efficiency, the nurses will examine the posterior chest first. The anterior chest confrontation and laceralist examination. The client is uncovered to the waist and in a sitting position. Sitting and lying position is preferred because it must maximize chest expansion. Good lying is essential, especially for chest inspection. And for the delegation, the assessment of the thorax and lungs is not delegated to the unlicensed assisted personnel. However, many aspects are observed using aquacare or recorded by the persons other than the nurse. Abnormal findings must be validated and interpreted by the nurse. So for the equipment, we have stethoscope, skin marker, pencil, centimeter ruler. Then for the implementation, we have the procedure, assessing the thorax and the lungs. By this, we have the preparation. First is to assemble equipment and supplies procedure. To explain the client what I am going to do it for it is necessary on how client can cooperate. wash hands, and observe other appropriate directions and growth procedures. Provide for client privacy in moment-grave or chest when it is not being examined. Determine client's history of the following: family history of illness, including cancer, allergies, tuberculosis, smoking, and occupational hazard in medication, or taking or swelling, swab, squeezing on pain. For the assessment of the posterior thorax, we have to inspect the shape and symmetry of the thorax of posterior lateral views. Compare the anterior posterior diameter to the transverse diameter. The normal findings for this is the anterior posterior diameter to transverse diameter in ratio 1 to 2, which is symmetry. Variation from normal is increase in the posterior diameter to the transverse diameter, chest symmetry. Before we proceed to the next assessment, I introduce myself. Hi ma'am, I am from Bison here. I am going to assess thorax and your lungs. Preferably the posterior thorax and the anterior thorax. Know your name. Can I know your name, sir? So your name is Tiger. The next is inspect the alignment for informities. To have the client stand for a lateral position, observe the three normal curvatures: cervical, thoracic, and lumbar. So, supposed to be this is a real patient. We have assess for lateral deviation of the spine. We use is observe the standing client from the earth. Have the client bend forward and the waist and observe from behind. So, the normal findings is spine vertically aligned, sternum column straight, and cervix and hips are at the same height. For diffusion from normal is exaggerated. Scoliosis and finus column deviate from one side open, accentuated when bending over. Shoulders or hips are not even also, for not normal. Next is palpate the thorax. For clients who don't have respiratory complaints, assess the temperature and integrity of all chest. For clients who do have respiratory complaints, palpate all chest for bulge and interness of abnormal movement. Especially if a fracture is suspected, avoid palpating it. The normal finding is skin intact, temperature, chest intact, no tenderness, no masses. For deviations from normal is skin lesion, areas of hyperthermia, lungs, blood depression, and areas of tenderness, movable stress. For the next, we have to palpate the for exhaustion. Place your palms over the lower thorax, adjacent to the spine, and fingers stretched out laterally. Ask the clients to take a deep breath while you observe the movement of your hands, attaining lag-in movement. Sir? Take a deep breath while I observe the movement of my hands and of the so, take a deep breath. Supposed to be efficient, take a deep breath. So I can say that it is a normal finding for the symmetry function is when a line takes deep breath, the tongue is moved apart and it moves distance, and at the same time normally the tongue separated 3 to 5 cm during the respiration. Because if it is not normal, the asymmetry or decreased chest expansion. Palpate the chest on both terminals. Place the palm to the surface of your fingertips or the normal aspect of your clan close it to place on the posterior chest, turning the apex of your lungs. The client surrenders this first as 2 mode or 1, 2, 3. If it does 2 step, moving your hand sequentially to the base of the lung, position the hand using your compare the firmicutes on both lungs and between the apex and base of each lung, either one hand or moving it from one side of the client to the corresponding area on the other side. You have simultaneously in the corresponding area of each area of the chest. You can repeat the word, sir. You can repeat the words to 1 or 1 or 3. Okay, go. 1, 2. So this is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Showing that the vital symmetry of vocal corpuscles is clearly at the apex of the lung. No pitch voices are well palpitated in high pitch of female. So it is normal. So beyond normal is the decrease of extremities or pneumothorax, increased extremities, or pneumonia. Next is for cause the thorax. Precaution nose rush resonate except over the scapula. Lower points of resonance is at the diaphragm at the level of 8 to 10 posterior. Note that the proportion on which no more elicit dullness. For deviations, normal is a symmetry in percussion areas of dullness or flatness over lung tissue associated with the consolidation of the lung tissue or mass. Because the diaphragmatic exertion movement of the diaphragm during maximal inspiration and expiration. The normal findings is exertion is 3 to 5 cm, 1 and 1/2 to 2 inches bilaterally in women and 6 to 6 cm, 2 to 3 inches in men. But diaphragm is usually higher on the right side. Deviation for normal is receptive exertion associated with lung discharge. So next is they auscultate the chest using the fat desk diaphragm of the stethoscope. Use the systematic zigzag procedure used in precaution. As the time, so to sleep, deep breath through the mouth. Listen at each point of the breath sound during the complete inspiration and expiration. Compare findings of each point with the corresponding points on the opposite side of the chest. So, sir, take a slow deep breath through the mouth, because I will listen at each point of breath sound during complete inspiration and of your expiration. 1, inhale, exhale, exhale. 2, 3, 4, 5, 6, 7, 8, 9, 10. So it is okay. So this is normal. So upon normal deviation is the adventitious breath sound, which is the crocus, bronchi, whispection, or the throat. So I guess our patient don't have it. So absence of breath sound associated with collapse and surgically removed lung flow. So our next assessment is, let's go to our next assessment of anterior thorax. So inspect normal. So if it is a pronounced deviation from normal abnormal, breathing patterns and sounds. So inspect the costal angle and the angle at which the ribs enter the spine. So dermal findings for it is the costal is less than 90 degrees and the ribs approximately at 45 degrees angle. Not normal is costal angle is widened associated with COPT. Palpate the anterior chest. Skin intact, clinical temperature, chest wall intact, no tenderness, no masses are considered as normal. So for not normal, the skin lesions are used for hyperthermia. Lumps, walls, and dispersion areas are tenderness movable structures. Next, palpate the anterior chest for respiratory exertion. Place the palms of both hands on the lower thorax with the fingers laterally along the lower ribcage and your thumbs along the costal margins. As the climb to deep breath while you observe the movement of your hands. For normal findings is well symmetric exertion, thumb normally separated 3 to 5 cm, which is the anterior thorax. Palpate the anterior chest, palpate the anterior chest, posterior for the respiratory exertion, palpate the tactile primitus. So, for not normal is the symmetrical or discrete respiratory exertion. Next is palpate the tactile primitus in the same manner as for the posterior chest. If the breasts are large and cannot be retracted by adequately for palpation, this part of the examination is usually serve as posterior primitus. The primitus is extremely decreased and breast tissue that is normal. So for not normal, serve as posterior primitus. So because the anterior chest systematically begin with above the clavicles and the supraclavicular space and proceed downward to the diaphragm. Compare one side of the lung to the other. Replace female breast for proper examination. Precaution nodes resonate down to 6 with at the level of the or over flat areas of heavy muscle and bone down on the areas of the over the heart and the liver and tympanic over the underlying stomach. So that is normal. For not normal is asymmetry in precaution nose area of dullness or flatness over lung tissue. So auscultate the trachea. The normal is bronchial and tubular breath sounds. For not normal is the adventitious breath sounds. Auscultate the anterior chest. These two sequence used in precaution beginning of the upper bronchi between the sternum and the clavicles. Normal is bronchial vesicular breath sounds. For not normals is again adventitious breath sounds. Then do aftercare to a patient if unable to help safe, or ask patient to do aftercare if able. Ensure patient on a comfortable position. And then do a hand hygiene. And lastly, document findings to the patient's record. So, that would be all. Thank you so much. I hope you learned everything and appreciate my efforts about the 5 assessment. Thank you so much. May God bless you all. It's my Pintor once again from BS1 Veneer. Thank you so much for watching. A happy evening
each and everyone.